Good afternoon, everybody. This is Joe Kahelski. I'm the CEO of WISHIN. Thank you for joining us today. We've got a great turnout for today's presentation. We're here today because hospitals are facing a major new requirement next year. As a condition of participation in Medicare, hospitals will soon be required to enable electronic notifications about inpatient and ED encounters at their facilities. Before we begin today's conversation, I'll just cover a few technical logistics. First of all of the attendees will be in mute mode throughout the webinar. We will have a question and answer portion at the end, and as we go along today, you'll be able to submit questions via the GoToWebinar control panel. Just click the question mark icon on the right side of the screen, and I'll be moderating the questions and sort of directing the questions when we get to that point of today's presentation. If we can't get to all of them, we'll follow up with those of you who had questions that we didn't get to by the end of the hour. We are going to make a copy of the webinar recording available and sent to all the attendees shortly after the session concludes. And we'll also include a copy of the presentation deck. So with that said, I'm going to introduce my colleagues from PatientPing. Our first speaker is Vanessa Kuhn. Vanessa is PatientPing's Director of Policy. She has nearly 15 years of experience in the public and private healthcare sectors. Prior to joining PatientPing, she was a program officer at the CMS Innovation Center for the Pioneer ACO model, and subsequently was a director of the LifeBridge Physician Network. She was also the chief of performance improvement at Behavioral Health Systems in Baltimore. Vanessa earned her PhD from Johns Hopkins University in Health Policy and Management. The next speaker will be Ben Marquardt. Ben is a Strategic Account Director for PatientPing. He has more than 10 years of experience working with health systems, ACOs, and independent providers across many value-based and fee-for-service initiatives. Prior to joining PatientPing, Ben was a health systems consultant for Thermo Fisher Scientific. Let's go ahead. So what's WISHIN's role here? WISHIN is co-sponsoring this webinar because the WISHIN network and the PatientPing network in Wisconsin are very tightly aligned. A few years ago, WISHIN and WISHIN's clients identified a need for more sophisticated notification functionality in the state, as well as the need to connect WISHIN to a broader nationwide network. That need eventually resulted in an agreement for an exclusive partnership with PatientPing to enable optional event notifications and related services for WISHIN's customers. We think it's a natural relationship, natural partnership. We use a number of different metaphors to kind of describe that partnership. One is the iceberg, with PatientPing being the layer of information above the surface. Sometimes we say ping is the knock at the door and WISHIN is what's behind the door, or you can think of ping as the first paragraph of the story that WISHIN makes available through its network. So we have that technical foundation and relationship that we've built, and that means WISHIN's clients are well positioned already to comply with a new federal rule. By virtue of you participating in WISHIN, your ADT data, that is admit, discharge, and transfer data, is already part of the PatientPing ecosystem. And that means that a good chunk of the technical work that you would need to accomplish to comply with the rule is already done. So with that introduction and a little bit of information about the partnership between PatientPing and WISHIN, I'll introduce Vanessa and she'll take it from here. Thanks for joining us.
Perfect. Thanks, Joe, and thank you for the kind introduction. I'm excited to get us started today, and thank you to so many of you for joining us for this next hour. We definitely understand that this is an extremely busy time and really want to make this session valuable to you and give you all of the information that you need so you can understand the new hospital condition of participation, or COP, that CMS recently finalized. And so with that in mind, really our goals for today are to set the context for the CMS interoperability and patient access rule, and then dive into the details of the new COP requirements. I'll also highlight some of the key considerations you need to take into account to make important assessments of your capabilities and decision about your readiness to meet the new requirements. And then my colleague Ben will provide additional details about how you can comply with the COP using the route solution. And as Joe already mentioned, we'll end the session with a Q&A, so feel free to submit those in the chat box along the way. So with that, let's jump right in. So to provide context, in March, two significant and complementary health IT rules were finalized that I'm sure everybody has heard about. But the first is the ONC Cures Act, or the info blocking rule. And the second is the CMS interoperability and patient access rule. And really both of those rules focus on improving information sharing, making data more accessible to patients directly, and also ensuring that data can be readily exchanged across the continuum to improve patient care and outcomes. And today we'll focus on the CMS rule, and in particular the e-notifications condition of participation, which is one section under that rule. Many of you, especially if you work in compliance, know that conditions of participation are really the most significant consequential regulatory lever that CMS has. COPs determine a hospital certification status and its ability to receive CMS payments. So in addition to that, as you're likely familiar, COPs are those requirements that get audited either by the state survey agencies or accreditation organizations like the Joint Commission. And if you're not compliant with all of the COPs, it can jeopardize your standing and impact your Medicare provider agreement status. So it'll be very important to meet and comply with the requirements. And just to reiterate, CMS published the final rule on May 1st in the Federal Register and included a 12-month implementation timeline for being compliant with the new COP. So that means May 1st, 2021 is the compliance date that you'll need to meet. So let's spend another minute here just on the intent of the rule, as it's really important for the context and understanding the requirements that are that CMS put out. So while, of course, some information sharing is already happening across different locations and regions, CMS drafted this COP really as a way to accelerate that information sharing with the intent of improving patient outcomes and to give those non-hospital providers specifically access to needed information about their established patients. And as stated in the final rule, CMS recognizes that hospitals play a critical role in terms of ensuring seamless care transitions, and that more information enables better care coordination and better outcomes for patients broadly. And with the new COP, CMS really hopes to support information sharing across the continuum, also ensuring that information is available to those providers for three specific purposes, namely treatment, care coordination, and quality improvement activities, and to eliminate any existing or remaining barriers to information sharing. So again, just the takeaway here is that CMS created a COP to improve cross-continuum coordination and to help eliminate any barriers for information sharing. So let's jump into the actual COP and the associated requirements. So at a high level, this is just a summary statement, and we'll, after the slide, go into the details of all of the requirements. But at a high level, hospitals must make a reasonable effort to send admission, discharge, or transfer, meaning ADT notifications, to post-acute providers, primary care practitioners, practice groups, and entities that need that information for treatment, care coordination, or quality improvement activities, as I just mentioned. And again, the compliance deadline is May 1st, 2021, and we'll spend the next few slides going into a little bit more detail on what the notifications actually need to contain and all of the requirements associated with them. So let's first look at the requirements. So notifications need to be sent by hospitals, psychiatric hospitals, and critical access hospitals. So those three main categories of provider types are included within requirements. And notifications have to be sent at the point of inpatient admission, discharge, and transfer, as well as the emergency department presentation and discharge. And they have to be sent specifically to the established primary care practitioners of the patients, the primary care practice groups and entities, post-acute providers and suppliers, as well as any other practitioner groups or entities that are primarily responsible for the patient's care. We'll define each of these categories in a little bit more detail in some of the slides that we have queued up. And the messages also need to contain, at minimum, the patient name, treating practitioner name, and sending institution name. So let's go a little bit deeper here. Let's first talk about who is required to comply. So I just mentioned it would be hospitals, psychiatric hospitals, and critical access hospitals. Now, of those categories, only those with EMRs or other electronic and administrative systems that have the capacity for notifications conformant with the HL7 2.5.1 standard will be subject to the COP. Pretty much every EMR or EHR has that capability, so most hospitals will be included within that. It's also important to note that within the hospital category is included not just acute care hospitals, but also LTACs, inpatient rehab facilities, as well as cancer hospitals, children's hospitals are also included within that hospital category. And we also noted on the slide specifically, if you want to go back later on and look at the references, the specific code of federal regulation subsections for each hospital type where that COP will be inserted. And they'll be part of the medical or the clinical records requirements. So next, let's look at the actual notifications themselves. And on the left-hand side, you'll see, as we already mentioned, the notifications have to be sent at the point of inpatient admission, discharge, and transfer, as well as on those ED events. And the ED requirements for notifications at presentation and discharge were newly added as the rule was finalized, really based on responses that CMS received after publishing the proposed rule. So that is a new incremental requirement that wasn't proposed, that was added in the final rule. And something else to note here is that notifications about any internal hospital floor or unit transfers are not required under the rule, but are certainly allowed to be sent if those are available, but are not a specific requirement that you'd have to demonstrate. And so if I identify the event types that lead to the triggering of those notifications and meeting those requirements, let's talk a little bit more about the notification process itself, which you'll see on the right-hand side of the slide. So first, the notifications can either be sent directly by the hospital or through an intermediary. The second thing to note is that notifications have to be sent in real time. So per the rule, notifications have to be sent, quote, at the time of the patient's registration in the hospital emergency department or the patient's admission, et cetera. So really at the time of is the indicator for that real-time nature of the notification requirement. Message, as mentioned on the prior slide, must include at minimum the patient name, treating practitioner name, and the sending institution name. Really what CMS is doing here is setting the floor or the minimum requirements on what information has to be exchanged. But CMS was very clear in their responses that they provided in the final rule that they certainly encourage any additional information that might be available to provide more clinical context. Initially, CMS had proposed to include diagnosis information as a required element, but that is no longer part of the full requirements. The diagnosis still remains optional and can be certainly wherever that's permissible under applicable laws and regulations. In general, I should just note here that CMS made clear that the e-notifications requirement will apply where permissible under federal and state law, and also needs to be consistent with patients' privacy preferences. And finally, there is no specific format on how notifications need to be delivered. As mentioned, hospitals just have to have the system that's conformant with the HL7 2.5.1 message standard. But in terms of how notifications are delivered, what they take is really left up to the hospital itself or its intermediary. So again, the takeaway here about the notifications themselves is that they must be sent in real time at the point of inpatient events or ED events, and can be sent by the hospital directly or its intermediary. So we talked about the hospitals that are covered under the COP, and also what the notifications must include. So let's spend a minute here on the recipient type and the purposes for the notification. So CMS specified, as you can see on the left-hand side, 3 distinct categories of recipients. And the first category is made up of primary care practitioners, practice groups, or entities. And those need to be established, meaning there is a treating active care relationship between the patient and that provider or that group. So these can be PCPs, primary care practices, FQHCs, entities like ACOs, where the PCPs drive that alignment of patients, and where they have delegated those care coordination activities to that entity. Now, the second category is practitioners, practice groups, or entities that the patient identifies as primarily providing his or her care. So this is something the patient can specify at the point of care, for example, during the registration process, or have other types of points of contact where patients might be able to specify those providers. And again, those recipients could be the patient's PCP or specialist, community mental health clinics, for example, multi-specialty groups, and others. And then finally, the third category are applicable post-acute providers and suppliers that transfer patients to the hospital, and those that receive patients upon hospital discharge. So again, those are the post-acutes that send patients or refer patients to the hospitals, and those that take patients and begin services post-discharge from the hospital. Those can be skilled nursing facilities, home health agencies, hospices, any other post-acute care provider. CMS also further clarified, just to note again on the right-hand side, that the recipients are those providers with established care relationships that need the information for one of the 3 outlined purposes, either treatment, care coordination, or quality improvement activities. All right, so we talked about the hospitals that are impacted, the notification details, as well as the recipients. So I wanted to go back to one point that I mentioned early in the presentation, which is around the requirement that hospitals have to make a reasonable effort to send notifications. So we should note here that the interpretive guidelines are still being finalized. They have not been published, but we can use the responses that CMS provided in the final rule, the final requirements, and the intent of the rule to define what reasonable effort means more clearly here. And so this will go through the next couple of minutes on sort of what that is and how you can think about meeting that reasonable effort threshold. So at a basic level, really, reasonable effort really requires hospitals to meet just the minimum requirements that are outlined in the final rule. That means sending those notifications at the appropriate time to the set of providers and recipients that are eligible for receiving them and that need those notifications for the 3 specified purposes of treatment, care coordination, or quality improvement activities. So knowing who those recipients are, that is really the crux of the issue here, right? You need to know who you need to send the notifications to, how those get routed, and then you can really check the box. So the hospital itself, or the intermediary that the hospital uses for this function, will need to determine who those practitioners and those recipients are. And so some of them will be identified at the point of care by the patient, like we had just talked about. However, there will be other, as you can imagine, lots of other practitioners that need to receive those notifications as well. Again, for example, those post-acutes or other practice groups or entities with those established care relationships that need the information for the specified purposes. Those recipients may not live, those recipients may not practice sort of right in the immediate region where the patient is or where your hospital is. So if you think about, for example, Medicare snowbirds that have different providers in different states and spend part of the year in a different geographic area, there's still a need for the information to be exchanged and for those other providers to know about any hospitalizations. And similarly, for patients that go seek care at a specialized tertiary hospital, for example, again, the general day-to-day primary care practitioner may not be right in that same location. So having the ability to send information back to the patient's regular provider or ongoing care practitioner will be important to consider here as well. So knowing those practitioners and sending notifications based on those identifications that the patient makes directly at the point of care, or meeting notification requests from those other providers that have those established care relationships with the patient will be important and can help hospitals demonstrate that they meet all of the requirements, check the box, know who all of the care relationships are, and send notifications accordingly. Of course, CMS did include some exceptions within that in the final rule, and so specifically stated that it's reasonable for hospitals to follow delivery of notifications to any of their specified recipients that don't want to receive notifications or don't have the capability to receive notifications, or where you just don't have enough information available to credibly and reliably establish the identification of the recipient. However, any of those instances should be documented and be evidence in case you do have a survey audit that you can show that you have the specific systems and procedures in place that you can send notifications, but in those cases, those thresholds weren't met, and you can credibly defend your position for not sending those notifications. On the flip side, just briefly, what would not be deemed reasonable effort is really first failing to put any processes or systems in place to meet those basic notification requirements to meet the applicable recipient's needs. Secondly, systematically excluding a full subset of the specified recipients. So we talked about those 3 categories. So for example, not sending notifications to post-acutes would certainly not meet reasonable effort. And then third, long or indefinite delays of those notifications. CMS was really deliberate in specifying notifications need to be sent at the point of the event occurring. As you can imagine, care coordination is really most effective in real time. So those notifications and the requirements really center around the real-time nature and not around batched or delayed notification sharing. So to do all that, and based on what we just talked about, there are really 2 capabilities that hospitals or its intermediary will need to have. And so on the left-hand side is the patient identified capability. What that means is that hospitals need to be able to send those patient identified notifications to individual providers. That means, again, those PCPs, other practitioners that the patient names at the point of care. And then secondly, on the right-hand side here is the provider requested component. Again, hospitals have to be able to respond to those requests from post-acute and primary care groups for notifications on behalf of the patients with whom they have an established care relationship. So we'll dive just a little bit deeper into both of those on the next couple of slides. So again, patient identified, that's the first capability, and it requires a process where patients can name or identify their providers. You probably have some processes in place already during the registration process or as part of your patient portal, perhaps, where that can be completed. Now, sending those notifications to those named providers really requires access to a directory of providers' digital contact information, as well as a mechanism that you can deploy to push direct notifications to correctly match providers in real time again. So having the ability to send notifications to the patient's identified provider is what you need from a capability standpoint for this element of compliance. Now, the second capability is that hospitals will need the ability to respond to notification requests from many different types of community providers, as we discussed. This can involve numerous complexities just centered around executing data share agreements with those different entities that need those notifications, processing diverse roster types or patient panels or census lists for those providers, and then managing kind of the frequent and real-time changes in those patient provider relationships. As you can imagine, especially on the post-acute side, the census lists on home health and SNF change really on a daily basis. So knowing how to update those care relationships and sending notifications accordingly will be a critical component of compliance here. So again, takeaway is really that hospitals or intermediaries need ways to manage and respond to the many different requests, which can certainly be complex. And before I wrap up in terms of just the information about the COP, I wanted to bring the requirements as well as the capabilities together and talk about the compliance surveys themselves. We know from the final rule that the e-notification requirements will be part of the Medical Record Services COP. And what that means is, based on the state operations manual in terms of what is published, that hospitals need to be ready for two specific sort of survey components and procedures. The first is a review of the organizational structure and policies, as well as an interview with the head of medical records. And the second is a review of a sample of active and closed medical records. For the policies component of it, so hospitals will really need to demonstrate and show documentation that explains how they meet the notification requirements that are outlined in the COP and what the procedures are internally to do so. And then for the records review, you'll need to be able to show through something like an audit report or a log that notifications have been sent to the specified recipients for those randomly selected patients under review. So you just want to be able to demonstrate that notifications have been sent to that patient's other providers out in the community. And as I'm sure you're well aware, hospitals will need to address deficiencies within the specified CMS timelines for termination procedures. So that means there will be 10 calendar days in which if you do have any deficiencies, you'll need to demonstrate a corrective action plan, and really that calls for very immediate remediation and will be essential should you not meet those compliance requirements. And I'll wrap it up. This really completes the discussion about the requirements, but I wanted to wrap it up and bring it all together just to review the critical considerations you should keep in mind as you make decisions about how you'll meet the new COP requirements and how you'll really assess any solution that can help you. So in particular, you should consider and ask how your own solution or third-party solution can meet these 8 specific points. So first, think about how you'll identify and send e-notification to post-acute providers. And then also how you'll send notifications to any cross-regional providers with established care relationships that need those notifications for their patients. You should also consider how you'll manage and ensure you have the appropriate data sharing rights in place, the security and trust between you and the notification recipients. And then also assess how you'll ensure that the notifications are actually sent in real time and are not unnecessarily delayed or batched. We talked about this quite a bit, but also consider how you'll manage and fulfill those continuous provider-patient relationship changes and manage the many endpoints to where notifications need to go. And we just talked about this, but what will you really use to demonstrate compliance once you do get surveyed? What will help you get that peace of mind? What kind of documentations do you need to have in place? What kind of processes need to be implemented? And something we haven't really talked about, but it's important to consider at least, and that is namely how you'll ensure that the community-based providers, so those notification recipients basically, what their experience is in this whole process. So you rely on those providers for referrals, you send your patients to them for ongoing care, and you want your brand to lead in the market and be a really good partner. So these cross-continuum partnerships and provider relationships are critical for the patient's experience directly and for the care that they receive. So making sure the COP actually helps the overall information sharing effort and making sure that other providers have a positive experience in all of this will be important and can really set your hospital apart from others. And then finally, you'll of course need to consider how you'll meet the compliance deadline by the May 1st, 2021 date. So it's a little less than a year. But just consider how long it will take to implement anything and making sure that you have all of the required documentation and processes in place. And with those considerations in mind, I'll go ahead and turn it over to Ben, who will give additional information about PatientPing and our solution route. So Nolan, Ben, excuse me, please take it away.
Great, thank you, Vanessa, and good afternoon, everybody. I think everybody can see the rule is full of nuances. And really, it requires hospitals to be very adept at some complicated processes. And before I continue, I want to point out one thing, and that's hospitals will need to do something. The decision will need to be made as to whether or not you're going to build a solution in-house or use an intermediary to achieve compliance. But the thing is, non-action is not an option when Medicare dollars are at risk under the conditions of participation. Now, the great news is the decision you've already made to be a member of WISHIN or PatientPing puts most of that work behind you. Over the next few minutes, I'll introduce you to PatientPing's solution, which is a fully guaranteed compliance tool with reporting and front and back end audit support. Now, if you're already familiar with PatientPing, you know that we have the largest national network of hospitals and post-acutes that are sharing data in real time for the purposes of care coordination. That network powers real-time ADT events to the tune of 100,000 e-notifications per day. You're probably starting to connect to the fact that this rule mirrors our business model really well, as our network contains the largest collection of ADT data feeds and e-notification requesters. One takeaway from the slide you see is that the decisions you've already made and the work you've already done has put you in a really good place to be compliant with very little work on your end. So let's see what that compliance solution looks like. This is where I introduce you to our compliance product, Route. So Route is your single solution to guarantee e-notification COP compliance. And I'll go into each of these in a little more detail over the next couple minutes, but the 4 pillars of the Route product are starting with patient-identified provider notifications. This is where we send patient-directed notifications when a patient notifies you of their provider. There are the capture and fulfillment requests from the community. And what I mean by that is we do the validating, we handle the incoming requests for e-notifications, and we ensure that end users can consume the data. We will provide a full audit trail with front and back end support along with reporting capabilities. And lastly, any intermediaries that request your ADT can be funneled to us so that it reduces your team's IT burden. And essentially, the Route product allows you to fully outsource the technical capabilities and workflow that are required for COP compliance. Now, let's look at each of these pillars closer, starting with the patient-identified provider notifications. Patient-identified notifications are when a patient provides their PCP during their hospital encounter. The PCP name comes to us across the ADT data feed, where a directory is utilized to locate the correct provider. Now, once we make a match with that provider, we send a direct message. Your EHR might already have some of this functionality today, and the differentiator I want to point out is that our product will include that full audit trail to help support you during a survey. The patient-identified notifications are one of those foundational capabilities of the rule really that Vanessa mentioned earlier, and the other one is provider-requested notifications. And before we fully dive into what community provider requests look like, it's important to understand the network and scope at which we are already providing notifications. And I already touched on the fact that it was a great decision to contribute your ADT data feed, but what does that really mean? And what it means is that you already satisfy compliance for the largest collection of community provider e-notification requesters in the country. Over 1,500 provider organizations representing over 11 million patients rely on PatientPing to receive notifications today. And that includes over 23,000 PCPs. That includes over 300 ACOs, POs, and other care roster contributing organizations, as well as over 470 home health agencies and over 590 skilled nursing facilities. But to add a little color to that, I wanted to put some figures to the e-notifications that power our Wisconsin network on a daily basis right now. And if we look at just providers in the state of Wisconsin who are already requesting e-notifications today, you'll see that we're delivering nearly 1,400 e-notifications on care events that their patients have locally and nationally. So whether healthcare is delivered locally when a CHF patient from a provider across town enters your ED, or nationally as a Cowboys fan comes to Green Bay for a playoff game and has a healthcare event. Having the ability to send real-time notifications is a requirement for the rule. And this graphic shows the scope of how our network powers e-notifications for Wisconsin providers today, again, underscoring why that partnership with WISHIN and PatientPing that's already in place helps you achieve compliance for likely your largest chunk of community provider requesters under COP. So now that you've seen a little bit of the data on the size of the network and the scope at which patient events are sent to providers in Wisconsin, and see that you're already compliant for those folks on the network today, it's important to turn our eyes to the gap, and where that gap lies is the requesters that are not on our network. Now, while the size of our national network will help with a large chunk of your compliance burden, hospitals tell us they have the most anxiety over providers not on our network. And that building a solution to ingest rosters, match patients, and pipe data to all those providers cross-regionally with different EHRs, or even into post-acute settings, will be an administrative and technical barrier to overcome. The portion of our product that we've built to fill that gap of requesting providers who are not on our network comes in the form of the requester portal you see in front of you. We'll provide a requester portal for your public and provider-facing websites, and a provider that reaches out to request notifications from your facility can be referred to that portal. Once they fill out the information on the portal, we will then validate that request, manage any data sharing agreements that need to be in place, and process their roster. From there, that provider can decide if they want to receive notifications from just your hospital, or if they want to receive notifications anytime their patient has an event anywhere on our network. And depending on how they answer that question, that provider has flexible delivery options to suit their workflows. Now that you've seen a little bit about how we address the patient identified and provider requested notification needs of the rule, let's move on to audit support and reporting. As with any compliance rule, audit preparation is a key consideration, and covering all of your bases is an absolute must. And Route also includes audit reporting with full audit trail of all e-notifications sent. Our audit report can be used by all of your internal teams during a CMS survey for any of those random patient record reviews that Vanessa mentioned. And the summary dashboard that you see in the top right, that top right graphic, this view provides you with an at-a-glance view of your data sharing and community providers at a national level. And then that bottom graphic, that shows you your detailed audit log. So any patient selected during an audit can be researched using a unique patient identifier to prove, yes, e-notifications were sent in real time, who they were sent to, and by what method. Now, to further support you during CMS surveys, a route policies and procedures documentation guidebook is also included in the package. And when it comes to CMS surveys for COP, for e-notification COP, the survey team must review your hospital's documented compliance policies and procedures. Route includes that written policy and procedure guidebook for use in demonstrating compliance during surveys. So during the implementation of Route with your hospital, we will work with your staff to ensure that they are trained on Route functionality and the guidebook content in service of demonstrating compliance during one of those CMS survey processes. The front and back end audit support coupled with that real-time reporting is an important differentiator. It's something that really can't be taken lightly as you consider your path to compliance. So now let's turn to the last pillar of our Route product. ADT routing to HIEs or other intermediaries is an optional feature of our compliance solution. So if an HIE in a neighboring state requests your ADT data feed on behalf of their customers, you can forward that request on to us. We will validate and satisfy that ADT need for them. And the purpose here is to reduce your organization's IT burden by only having to maintain the one outbound ADT data feed that you're already sending either to WISHIN or PatientPing instead of multiple feeds to multiple recipients. Now, with that being said, that's the last of the 4 pillars of the Route product. So we'll look at our guarantee next. We are confident that with Route, hospitals will be fully compliant with the e-notification COP, and we back that up with our compliance guarantee. So if any Route customer is ever found to have e-notification COP deficiencies during a CMS survey, as a result of Route, we will deploy a PatientPing compliance expert on site to help resolve the issues and develop the required corrective action plan within 10 calendar days at no cost to ensure that you are compliant with this COP. And to go a step further, all WISHIN hospitals are also eligible for incentivized pricing. And next, I'd like to show a quick quote from Rick Lang at Doylestown Health. And I'll give everybody a moment just to take this in. Now, Doylestown they're an independent nonprofit hospital serving suburban communities around Philadelphia, as well as Hunterton and Mercer counties in New Jersey. And just one of the hospitals who have already chosen to trust PatientPing as their compliance vendor of choice for this e-notifications conditions of participation. And Rick does a good job touching on the complexities of the rule, the post-acute request volume, and really the focus that PatientPing has as reasons that made this an easy decision for them. And as he mentions, in a COP situation, an inadequate solution is a risk that really can't be taken. And now for my final slide, we talked a lot about why PatientPing is a trusted intermediary for COP compliance, and that's really based upon the strengths of 3 factors: our network, our product, and our team. We have a world-class team of company leaders, board members, and advisors with deep experience in both policy and interoperability. This team has prior experience at organizations like CMS, Commonwealth, Epic, as well as Cerner. And with a robust network, a strong product, and a world-class leadership team, PatientPing meets WISHIN's network and hospital partners in a perfect scenario to help you achieve compliance quickly and easily while keeping your focus on the burdens that healthcare faces today. Now, that includes the product section of our presentation today, and I'll hand it back over to Joe to field any questions that may have come in through the audience.
Okay, thank you, Ben and Vanessa. We have a few questions, and as I said at the beginning, we'll we'll take as many as we can, and we'll follow up on the rest. First question is, what about long-term acute care hospitals?
I'm happy to take that, Joe. Yeah, so they are actually included within the COP requirements, so they will be impacted and have to comply. As I mentioned, the definition of hospitals is fairly broad under those CMS regulations, and will include acute care hospitals, LTACs, inpatient rehab, specialized cancer hospitals, children's hospitals. So all of those will also be included within the COP, as of course are the specifically called out psychiatric hospitals, as well as critical access hospitals.
Okay, next, we're seeing a few questions about Epic systems, and what information do we have on how the Epic EMR might treat this requirement?
Yeah, Joe, this is Ben. I can take that one. And first of all, it totally makes sense that folks might turn to, or might think to turn to Epic immediately, considering Care Everywhere and Epic standing in the Wisconsin market. And as you saw from the previous slide, our leadership team is made up of folks who have vast experience across the EHRs and interoperability landscape, including Epic. And those folks have built our solution to fill the gaps between what this rule requires and where healthcare IT sits today. So, some of those gaps include when it comes to an EHR like Epic, sending notifications to non-Epic entities, sending notifications into the post-acute community, and also ingesting rosters from across the country. Now, really to help you vet those capabilities, we really encourage you to review the list of considerations Vanessa talked about earlier, and whether Epic is able to meet each one of those. And we also suggest looking at the checklist that's referenced here on the screen you see as part of the materials that we'll send to you following today's presentation. And that'll give you a good opportunity to really understand what those considerations are and pose the question as to whether or not those are going to be satisfied with an EHR at this moment.
Okay. What is the obligation to notify a provider if the patient doesn't reveal who their PCP is, or maybe doesn't even have a PCP?
Yeah, I can take that one again, Joe. Great question. In the case that a patient doesn't know, doesn't reveal, or doesn't have a PCP, then on the surface, you might not be held responsible for sending a notification to that provider. But one of the nuances is that if they have a primary care provider or an ACO group that's requesting e-notifications on behalf of their patient panel. So in the event of a patient that doesn't know who their provider is, or that they're part of an ACO, at the point of a care encounter, we still believe that hospitals are required to send these e-notifications. So we can help do that through our processes outlined in route and how providers go about requesting e-notifications. Our matching algorithm is certified by the OMC with a 99.99% match rate. So in the case where a patient is unable to give their PCP information and another group is still requesting information on that patient, filling any gaps that come with relying on, filling any of those gaps, you should feel pretty good about that. We'll be able to satisfy that regardless of the situation.
Okay, maybe time for a couple more. Do you have to get consent? And my screen just went away. Hang on just a second. Do you have to get consent from patients on sharing their information?
I can take that, Joe. So the short answer is no, you don't. It really falls within the HIPAA TPO exception. So because these notifications are for treatment, care coordination, and quality improvement activities for established providers, you don't need to get special consent for sharing information. Obviously, CMS did note, all other applicable state or federal laws have to be taken into account and met. But from a consent perspective and from a sharing these e-notifications, the HIPAA standard would apply, and you don't need to get special consent for these e-notifications specifically.
Okay, another one here. When should we begin vetting different solutions in order to be ready for the deadline next year?
Yeah, I can take that one, Joe. So to answer this question, we first need to look at the compliance date. May 1st of 2021 is only, I guess, about 10 months away. And as many of you know, 10 months in healthcare is the blink of an eye. Hospitals will need to determine, again, do they want to build this solution in-house or outsource to an intermediary? In-house builds take time, as you'll need to know if and how you want to handle any data sharing agreements. You'll need to have a mechanism to ingest rosters. You'll need to, especially when those rosters from post-acutes turn over daily based on their census daily. You'll need to build a matching algorithm to ensure appropriate matches are made, and have a way to actually send the e-notifications in real time to all requesting and patient identified providers. But then on the flip side, working with an intermediary takes the lifting off your hands, but still requires contracting, approval processes, and budgeting, which all of you know can take time. And given all of that, there's still concerns about additional COVID resurgences. So the COVID burden over the next 12 months is still very real, very uncertain, and an important variable as well. So, given all those uncertainties and timing needs that compliance requires, we strongly recommend that hospitals start forming their compliance strategies as soon as possible.
Okay, I think we've had a couple of different versions of essentially the same question. I think we've checked all the boxes on the questions. And we will be going back through the questions and make sure that we've given complete answers, and we'll get those answers out to the extent that we want to sort of amend or supplement those answers. So thanks to all of you who have participated. We've enjoyed being able to tell you about the PatientPing Route product. You can see the contact information and additional resources there on the slide. And again, we'll send out responses to the questions and the slide deck shortly after we end here. With nothing else, I don't know, Ben or Vanessa, anything else we need to cover?
No, I think that wraps up our session. Thank you again, everyone from the PatientPing side of the house as well for attending. We really appreciate you being here and taking time out of your day. And yeah, please look out for an email from us, and have a great rest of your day and a wonderful weekend ahead.
Thanks, everyone.
Thanks, everybody.